application in abdominal imaging of organ segmentation. The first thing is, one of the most obvious is volumetry, for example. And I take the example of liver surgery, or also extraction of 3D volume of the prostate from, for example, from MRI, and this can be used can be imported on the ultrasound equipment to perform fusion biopsy. Or then we can also study carefully the organ boundaries. This can be performed with ultrasound, and you can see if the boundaries are smooth, then it's probably a normal liver, and if they are irregular, you can have cirrhosis. And finally, we can use organ segmentation for treatment planning, and we can actually even apply this daily to patient anatomy, and just prior to fraction, to maximize the target coverage while minimizing the toxicities to the surrounding organs at risk. So I'll just give you briefly some examples. This is a study using, as you can see, 3D convolutional neural networks to segment the liver, and the results are very good. This dice similarity coefficient is near 100, which is that means it's near perfect, and it compares basically the manual contouring, which is the red line, with the green line, which is the algorithmic segmentation. So this is an interesting and good result, and we can, for example, apply this to the kidney. And again, here this is, for example, a study measuring kidney volume in patients with polycystic kidney, and measuring the evolution of the volume, the growth of the volume with time. So you can get an idea of when, for example, these patients should undergo surgery. And again, you can also segment all the organs, and this is an example, and this is important especially for MRI-guided adapted radiotherapy. So then the next step is assessing organ disease. And for example, we need to, if we want to measure fibrosis and steatosis, we can do this by using neural networks, or we can do some further partitioning of organs. For example, we can separate the cortex of the kidney from the medullary part, and we can do some functional assessments. And this is an example of measuring fibrosis stage with MRI, from MRI images, and in this case, the deep convolutional neural network extracted as an output had this score, which is called the fibrosis deep learning score, and this score compares very well with the fibrosis stage. Okay, this is the area of the curve, which is quite interesting. Or this is what I said before. We can, with segmentation method, to identify different parts of the kidney, and of course the relation between the volume of the cortex and the medulla might change during disease, and this is just a preliminary study. And one of the advantages of these methods is also that they have a very low computational time. So next step is lesion detection. So of course it's important. For example, or to assess tumor burden longitudinally by CT and MR serial evaluations, and this can be used for assessment of response to treatment. Or again, if you see the tumor, you can guide the biopsy better, and this is the time that this could be employed, for example, in prostate fusion biopsy again. And here I have some problem again. I was more lucky than Professor Francone.
You lasted longer.
Okay, so I mean, at least I got about one-third of the way.
Can you please help from the technical support? Thank you.
Okay, so can you go on to the slide? One more? No? A couple more? I can go on my own, I guess. Okay. Okay, so we said that. Okay, this is an example. This is not neural networks. This is machine learning. So this is work from our group, and you can see here that the computer generated color-coded maps of the tumor. The tumor is in the red color, and the rest is the less probability. These are probability maps, and you can see that where the blue is low probability of having tumor. And of course, this way you can clearly delineate the tumor, measure the volume, and also probably this can be inputted in the software for fusion, and you can perform better perfusion biopsy. Or again, this one is a detection of renal cyst, and this is not really, probably not so useful from a clinical point of view because this is an easy task for the radiologist, but and you can, it's curious to see that sometimes the computer, the algorithm messes up because here we have hydronephrosis and the computer is not able to, it has actually classified this as a cyst, and these small lesions have been misclassified as non-cyst. Well, going on, just we can broaden this. We can go from narrow to strong artificial intelligence, and we could potentially use this system, these algorithms, to detect any kind of lesions in the body, including, of course, abdominal lesions. And this is a very interesting paper from NHI. And it shows that actually you can detect lesions. The liver is probably the best detected. Lesions in the liver are very well detected with this system, and while soft tissue and bone lesions are, they have this algorithm has very poor performances. And this has been trained on a data set of over 30,000 CT scans. So next step is segmentation and characterization. And so we're going from organ, therefore, to lesion segmentation, again for treatment planning, assessment of tumor burden, differential diagnosis, and radiomics analysis. So briefly, some examples again. And this is segmentation of a rectal tumor. It's, of course, useful for treatment planning and radiomics analysis. The results are not really so good as in other cases because you can see here that dice similarity coefficient is a bit lower, but it's pretty obvious that these kind of tumors it's much more deep. Okay, so this is a very interesting work because it measures new metastasis examination. Then it co-registers images from baseline and from follow-up scan using the tumor centers, and then it identifies, in this way, it is able to identify new lesions like this one. And this is what comes out from this is an example. Here you can see then once you have identified the lesion, of course, you can segment them. And here the red lesions are the old lesions, and the green lesions are the new lesions. So you can imagine the impact this kind of software can have on for example, assessment of tumor response. And characterization, this paper from radiology, about a year old, and you can see here that the authors have subdivided patients in different categories. Category A and B are malignant, category C and D, D and E are benign, and this is undetermined, and they have large training data set, and they were able to actually very well distinguish patients that have malignant lesions from patients that had benign or indeterminate lesions. And finally, let's say also just keep in mind that we can add to imaging also clinical information and therapeutic features, put everything together, and use neural networks to extract, to actually predict treatment response to in this case, in patients with hepatocellular carcinoma and undergoing intra-arterial therapy. So this is a new topic we haven't been talking about today, but I think we should take this into consideration, not only radiologic images, but also clinical and genomic and so on. So we should go towards a more holistic approach. So what is still needed to be done here in the topic of abdominal imaging and artificial intelligence? Well, first of all, we are really narrow. We are really, most of the time, adopting very narrow artificial intelligence. We need to go to a more strong. At least we need to put all this, if we want to use all this data or all this information, we need to put this all in one tool. Okay, for example, for the liver, we need all these functions and quantifications put in the same program. The second thing that I want to stress is that we are still very far behind in relatively to standardization and clinical validation. And so we need really to assess reproducibility and repeatability. For example, we are really noticing that when performing radiomics analysis, just some features are really influenced even by small changes in the segmentation. Okay, just small changes from two different radiologists segmenting, just a little difference, then the features might be very different. And we've also observed that different softwares yield different results. So I mean, we really need to standardize. We need to also assess that there are differences between scanners and protocols. There are no prospective studies. And high quality data, we know this is not so easy to have. How about companies? Well, companies are black boxes. This is what I believe. There are no data on validation from companies, and we don't really know if their software is reliable. Very few people have inside access to data from companies. And finally, ethical issues we haven't been talking about. So I really want to stress this. Who is going to be responsible if something is going wrong? Okay, the pilot, which means the radiologist, or the company, or FDA, or the passenger, or the patient. Because maybe, you know, in the future, the patient will some kind waive responsibility to the radiologist in his informed consent, and then in that case, nobody is responsible. Or maybe the patient is. Just the patient is responsible. And so also remember human-machine interactions, because we might have the most beautiful software in the world, but if radiologists are not used to working with computers, then it might be difficult. I'll show you this example is a CT CAD, computer-aided diagnosis tool we developed starting in 2003, so that was 16 years ago. And this eventually became a product, but nobody, well, I was very affectionate to it, but nobody else was using it because nobody really trusted CAD. So there was not so much trust. And so eventually this company failed, and so I'm not also able to use it anymore. So in the end, if you ask me, is artificial intelligence ready for prime and abdominal imaging, I would say now, no. But life lesson is that no doesn't always mean never. Sometimes it just means not yet. Thank you very much. Thank you.